Hello and welcome to our third episode of HCQ TV. I'm Melissa Fox, CEO of Health Consumers Queensland, and I'm delighted to invite you to join us today from across Queensland and across the country. I'm honoured to be joining you today from the land of the Yuggera and the Turrbal people. I would like to acknowledge the traditional owners of the land on which we are and the lands on which you all are. I acknowledge their elders past, present and emerging. And I acknowledge the role that we all have to work together to improve the health outcomes of Aboriginal and Torres Strait Islander people. Last week's episodes on digital engagement and on co-design are now available to view and watch online. So if you didn't get the chance to join us or you would like to watch the session again, please go to our website sharingpower2021.com.au. So in 2020, Health Consumers Queensland delivered training online to hundreds of Queensland Health staff. The most common question we were asked was, how do I engage with hard-to-reach consumers? Staff asking this question recognise that they need to engage with a diverse range of consumers but don't know how or are fearful of getting it wrong. Often they don't have a lot of support through their organisations and are lacking in experience. Engaging with these populations is clearly a big gap in knowledge for health staff trying to forge partnerships with consumers. And in demonstrating this, we have the highest number of registrations for today's session, with over 320 people who have registered to join us online. To try to bridge that gap, we have invited some consumers to join us today to reflect on that question. With me here is Christos Papadopoulos, who comes to us with a wealth of experience in public health, consumer rights and Indigenous affairs, and more lately in consumer representation. Welcome, Chris.
Thank you.
By video, we welcome Ellie Buchan, a lifelong consumer of Queensland's public healthcare system and a passionate advocate for person-centred care. Ellie's consumer roles include the Marta Youth Consultancy, Queensland Child and Youth Clinical Network's Clinician Collaborative, and Health Consumers Queensland's Youth Reference Group. Welcome, Ellie. Our other consumer coming in via video is Hamza Vayani, who currently holds several appointments in a range of health and mental health related roles, from a lived experience carer and health consumer informed policymaker and advocacy perspective. Welcome, Hamza.
Thank you.
We are also joined by two professionals passionate about empowering consumers to have a voice. Westmoreton Health's Senior Engagement Officer, Trisha Hansen, and Health Consumers Queensland's Anne Curtis. Thank you for both joining us.
Thank you.
So, hard to reach is a term that we hear frequently in the course of conversations with staff about consumer engagement, but rarely do we hear consumers describe themselves as hard to reach. Ellie, are you hard to reach? What do you think when you hear that phrase?
Okay. Is that better?
We can hear you now.
Okay.
Thanks, Ellie.
Wonderful. No, I don't believe that I am hard to reach. I think in general we need to diverse our communications when we are engaging with consumers.
Yeah, absolutely. And we're really, really grateful to have you here today with your experience of someone living with a disability and such a passionate youth advocate. And we're looking forward to hearing from you in particular about how to engage with young people. So I'll ask you those questions later on in the episode. Christos, what do you think is a better way to describe these consumers?
I'd like to follow on from Ellie's point, and this. The term hard to reach is a social marketing concept, and it has been used mainly in health. There's a problem with hard to reach because it suggests that we are talking about a homogeneous group and that inside that homogeneous group are people that we cannot reach. In fact, experience indicates that we can reach all the varieties of population that we have, it takes innovation, it takes strategic thinking, it takes our ability to be innovative, and more importantly, it's costly, because we are reaching further and further into the society. However, I think here in Queensland we have done a great job. I have been following Health Consumers Queensland for the last year and a half now, and their relationship with the department. And I think that probably what the name that we need to give this hard to reach group is something along the lines of hidden knowledge, hidden experience, hidden support for services that as yet we are not reaching.
I love that. I love that. Thanks, Christos. So Trisha, what do you think staff mean when they describe consumers or groups of consumers as hard to reach? And what supports have you observed are currently on offer to support staff's understanding of the diversity of consumers accessing or not accessing services and how to engage with them?
Yep, thanks, Melissa. I guess hard to reach, and I agree with what Ellie and Christos were saying. Health is really good at using jargon and terminology and trying to box people into really small boxes, whether they fit there or not. And when I spend time with our staff to talk about what do you mean by hard to reach consumers, really what it boils down to is them lacking the understanding of how to engage with some consumers. And there's a really big difference there, because having those conversations with them, human to human, and talking about it not just in the context of a broken arm or someone that's come in through ID, means that we start broadening that lens and saying everyone is a member of our community, and more importantly, an equally powered member of the community. And so why would we talk to one person differently to how we would talk to our colleagues or anybody else? And I guess in theory that's really easy to say, and in practice, I guess our team has been trying to enable our clinicians and people working in the hospital and health service by raising to their awareness some of the barriers potentially of understanding how to engage with different people within our community and our consumers. And also opening the blinkers a little bit and saying, well, consumers are not only the people that are walking through our doors, but it's the people that in the community that we serve. And I think even just having a slightly different conversation with people, not just in a clinical sense, but in the lunchrooms, in the lifts, I think it's starting to change the way that we're using that language around hard to reach. As one of our consumer reps really, really adequately put it, health doesn't humanise our service. And so humanising our service and the way that we talk to our consumers in our community is something that's really stuck in my mind.
I love that. That's so important, humanising services. And I love flipping that, instead of talking about consumers as hard to reach, thinking about how to reach. That's a really powerful statement. And we know you're really passionate about community engagement. So Trisha, I'm looking forward to asking you more about how you do that later. Thank you. And so don't forget, everyone who is online, please do use the chat function. We've got our team on standby to send them through to me here in the studio. Your comments in response to these questions that we're asking the panellists, and also your questions for the panellists too. So please don't be shy in coming forward. So Hamza, you wear two hats, one as a consumer and carer representative and another as a staff member engaging with health consumers from many different cultural backgrounds. From this dual perspective, what insights can you offer to people working with consumers from diverse backgrounds?
So first thing is, this whole thing about hard to reach, I'm just going to knock it on the head. It's a furphy. There's no such thing as hard to reach. Right? It's actually about our effort and our ability to be inclusive of all of our communities. The fact is, we are privileged in Australia where healthcare is a right, but what we have to do though is recognise that healthcare, access to healthcare is not always accessible. And often when you start talking to people about some of the issues around access and equity, the light bulb comes on, that we actually sometimes have a healthcare system that's designed to lock people out, which is why then we have this misnomer around people being hard to reach. So to sort of peel back your question further, Melissa, around what does that look like from a community perspective and what does that look like from working within a healthcare system or service perspective? Well, I think from a consumer perspective, I think I share all of the comments. I don't really want to labour the points that were so well made by others, that it is about community engagement. It is about understanding our communities. It is about humanising healthcare. From a system point of view, we are notorious in Queensland Health and in agencies that deliver healthcare services for good reason sometimes in defining who we might be serving or who our constituency might be in terms of a healthcare service. But we've got to be really mindful that in thinking through what our service is, that we're not using that as labels or excuses to not understand who we should be serving.
Absolutely, absolutely. And a lot of what you've just talked about now does remind me of engagement during COVID and how the system has attempted to engage with many different populations. I'll come back to you and ask you about that in a little while too. So thank you very much. Now, I am delighted to welcome another guest to our studio who's joining us today. We're joined by Janet Blair, a well-known member of the Aboriginal community with many years' experience in delivering maternal and child health services in communities such as Doomadgee, Mornington Island and Nurundangi. I'm delighted to invite Janet now to acknowledge the traditional owners of the land on which we are gathered today. Thanks, Janet.
Thank you. Today, during Reconciliation Week, I would like to acknowledge the Turrbal and the Yuggera people, the traditional custodians on the land on which we meet today. I acknowledge their elders, past, present and emerging, and I also acknowledge their laws, customs and traditions. Thank you very much.
Thanks, Janet. It's great to have you here today. So on to the next question. So as we've heard today, we've started to hear reference about different ways of engaging with different populations and how that we've observed that making a real difference to the different groups of people that can be reached. One way of getting genuine input from people who might not otherwise engage, we have found kitchen table discussions and in some communities yarning circles. And Anne Curtis from Health Consumers Queensland has been leading our kitchen table engagements for HCQ for 3 years now, covering a huge variety of topics, but including, just to name a few, aged care, palliative care and end of life, digital health, mental health and so much more. And they have been really warmly welcomed by consumers and by those in the health system who want to hear from a diverse range of consumers. Anne, can you begin by giving us a quick outline of what a kitchen table discussion is, how many we've done and how they differ from what we might call traditional engagement methods?
Sure. So at this point, after nearly 3 years, I think we're about to hit 200 kitchen tables that we've facilitated across the state. And where they differ is that it's consumers who actually lead the consultation. So it's consumers who actually we recruit as hosts, and we call them hosts. They go out and they bring together people from their networks, from their community who have an interest in the subject that the discussion is about, and they choose the date, the time, the venue. They all have the same questions, all the hosts, they do the discussion, they send back a report. And so it's people in community feeling safe in an environment where they're in a circle of support. And for a lot of people, it's actually cathartic. And they'll say, you know, this has been really cathartic for us. And the other great thing about it is these are people in community who may never be reached in any other formal way. And also, they will not attend a focus group or they may not fill out a survey. So it's a totally different way of putting people around a table with, you know, we give them a catering budget and, let them have that discussion for themselves. So they learn from each other at the same time, which is an added value.
That's great, thanks Anne. And Janet, I understand you have held some kitchen table discussions, some yarning circles. I'd love to hear from you your experience of hosting them and the impact that you've seen, including, we know that sometimes it can be really difficult to be a lone consumer voice sitting on a committee. What have you seen of the benefits of many voices being shared through the kitchen table?
They're very powerful. When you create a safe space for women to gather and to talk and to yarn, we say yarning, Aboriginal people and Torres Strait Islander people, we say yarning, getting together. These women would come together because they want their voice to be heard and they've never been asked before, so it's quite new to them. And the first one I did in a regional setting was incredibly powerful, that we talked for more time than, what was allowed, and they didn't want to go back to lunch, and they go, we just want to have more of these conversations about things that are meaningful for us. And I guess I've seen, once they start talking, women can't stop talking because it brings up so many things. And I think being a community person and being an Aboriginal person, it facilitates a safe space. And their word is being heard, and because I'm writing it down and sharing it, but also what it does is create conversations to take home to their families, The conversations just don't stop there. It brings up other stuff. And so I've worked in other regional places where I've held the yarning circles, and the same thing happens again. Women just come out with the most amazing things, and I always believe that when you educate a woman, you educate a family, you educate a community, and that's how you change the world. And we know that I love men, don't get me wrong, I love men. I think men have a great purpose, but women are the backbones of families, and it's that coming together, and then they share it with the men in their family, the young men in their family, the old men in their family. I've seen changes, and I see, and I've had to listen to some sorrowful stories, painful stories as well as joyous stories, but it's an opportunity to do it in a safe place, because I understand all the women that I've been talking to are either Aboriginal, Torres Strait Islander, South Sea Islander, or they have a child who is Aboriginal or Torres Strait Islander. And so now that it's Reconciliation Week and we talk about action, it's about those words on paper becoming action, not another consultation process because we're over-consulted, we're over-researched. We need to see that there are some concrete evidence and outcomes of what we're talking about and changes.
Yeah. Absolutely. Well, thanks, Janet, so much for hosting those conversations. We're really grateful, and I'll come back to Anne later on in the session for her to share the impact that she has seen on these kitchen table conversations. And you've reminded for me the importance of especially the responsibility of organisations such as ours, not just to be going out to communities and seeking input from what the health system wants to know about, but really creating those opportunities for what matters to all different communities and what do they want to share with the health system. Hamza, do you think that during COVID there were enough opportunities for multicultural, culturally and linguistically diverse refugee, international student populations to raise with the system what they needed in terms of the pandemic response? And did the mechanisms exist that helped facilitate hearing their voices?
Look, I'd say it was a mixed bag. I think there was really excellent examples of good practice that are still continuing. There are challenges as well. So, look, we all know that COVID is one of these things where, our friends, our brothers and sisters in Victoria are back in lockdown again. We've been very lucky and fortunate in Queensland so far, so good, touch wood, and let's hope it stays that way. But I think, look, the good standout opportunities for engagement were that the Department of Health did organise and does continue to have a COVID-19 working group that's focused on cold population. So I applaud the department for that. That's good, and it engages a range of stakeholders. From a community point of view, we were a bit sceptical, but I'm also involved in an organisation called World Wellness Group, and we advocated for a multicultural connect line. It's the first of its kind anywhere in Australia, and an example of creating a quick stand-up response where if communities are anxious or wanting information, that's available in the form of a helpline. We were skeptical in some ways, if I'm very honest, about whether the model would work. And the reason for that is that, generally speaking, multicultural communities and the idea of communities ringing up a helpline in of itself is a bit ambitious and a bit pie in the sky, if I'm really honest. What's made the model work has been that we've been able to employ bicultural workers who are trusted within communities, who've been able to go to places of worship like mosques, gurdwaras, temples, mandus, and other places where communities coalesce. They've even engaged with people like hospital chaplains, because hospitals do engage chaplains of different faith and community backgrounds. So we've been able to have pretty extensive reach. And I think it was because of that reach and that relationship that communities that are seemingly hard to reach were not hard to reach, because we said, look, we're in COVID and the normal rules of engagement around face-to-face because of social distancing and so on is not always possible. But here's a medium, here's a structure which is run by people who you can trust with engagement from your community. And that's sort of how we've been able to get phone calls all the way up from the top end to Southeast Queensland and beyond. In fact, we've actually had inquiries from interstate saying, wow, you guys have got it together in Queensland, so how can we replicate that? So let's hope that there's opportunities to build on what we've been able to do over here. The risk, though, is that when we're talking about multicultural communities, or any community, is never to homogenize people into whole groups. I think, our friends and colleagues in the department do their best to engage, and sometimes they're under the pump and it becomes a bit hard. Which group do I talk to? And it'd be a lot easier to have a peak body to be able to do that stuff, I think, from their perspective. But the fact is, you've got to build relationships, you've got to build trust, because as they say, building trust and credibility takes eons, but to lose it takes seconds. So, investment and good quality relationships is really important.
Yep, I've really observed that being at the heart of the last 12, 18 months. It really has been those pre-existing relationships and the time being put into new ones. Ellie, can I come to you and ask you about engagement? As a young health consumer living with a disability, what are the factors that make engagement accessible for you?
I would say choice and control. So, for example, today there are several people in the studio, but unfortunately I couldn't join you in the studio, so I'm joining you from my bedroom at home. So I think we need to look at having that option for people. Engagement isn't difficult, but we need to diversify the way that we actually engage with people and give them the opportunity to engage in a way that best suits them and their way of life.
Excellent. So the increased use of digital technology during COVID has increased your engagement and your ability, your opportunities to engage?
Absolutely. I only became a consumer rep about 15 months ago, but the majority of my opportunities have actually come through HCQ's youth reference group and our framework that just got launched about 2 or 3 weeks ago. So, I mean, that's a great example of engagement. There's a misconception that young people just aren't interested in engaging, which is simply, it's a myth. We had about 25 people in our reference group, and they come from all across the state and all different backgrounds. So we were very well represented, and hopefully we've come up with some great framework to really improve the health system as a whole for young people throughout Queensland.
Absolutely. And all of that was done online with your meetings and using the Slack channel and drafting that strategy. And we were so delighted to have so many of you face-to-face for the launch with senior members of the health system just a few weeks ago. So Anne, can I come to you, because not only have you been leading our kitchen table conversations, but you've been leading another really interesting project since 2018, working to listen to and amplify the voice of health consumers in prisons. Could you talk about your journey supporting that work and the impact that you've seen it have?
Yeah, that was a really interesting one. So I joined a committee with Queensland Health and many other stakeholders, including Queensland Corrective Services, in 2018. And as the consumer organisation, there was a statewide review of prison health services, and I was there as the consumer voice, which is very difficult because, one, I haven't been to prison. Two, I don't know any prisoners, and it was really interesting because you talk about hard to reach, and it was kind of like, well, how do I reach the people I actually need to consult with? Because I had that role of consulting with the consumers in this situation. And it was walking into a meeting one day of this collaborative, and it was a senior corrections officer who said to me, "Anne, are you coming in to talk to the consumers?" And I said, "Well, how do I do that?" And he said, "Well, we invite you in." And so they opened the door for me, and I was able to go in 2018 with support from Queensland Health to 7 correctional facilities and engage with as many prisoners as we could. I think it was around 89 at that time. And from that, I was able to feed back their actual viewpoint into that statewide review into prison health services. Out of that, there was an Office of Prison Health and Wellbeing established by Queensland Health. There has been a strategy for the next 5 years developed, which is just fantastic because it's all about prisoner health and wellbeing. I was able to go in and do training, and still doing that training now with prison health staff and corrections officers around prisoner healthcare rights and how to engage with prisoners, because they are still they are consumers of a health service that is for prisoners, that is conducted in their facilities. And so lately also I've just done a return visit to those same 7 correctional facilities, and I met with 112 prisoners, again, to bring their voice back to Queensland Health and Queensland Corrective Services around, what matters to them, what's important to them, and what improvements and access issues are there that need to be addressed. And from that, we'll do an infographic from Queensland Health that will go out to the prisoners to say that they're being heard, and hopefully change will occur.
It's an area that we're really proud to support and work for improvement for their health outcomes. They're just as deserving of good health care.
They're one of those voices that, I think everyone would think are too hard to reach, and yet they are some of the most vulnerable people in community. And if you can help them in while they are incarcerated, then there's a better chance that they will go out healed into the community or find a way in community to stay out of prison.
Absolutely. So we have one comment. Please don't forget to pop questions and comments in the chat. Maybe we're answering all of your questions, but I'm guessing not, so please pop them in. There's a comment here. Is there a case for the term lesser heard consumers? It's not a criticism of anyone, but we know that some consumer groups or segments are more often heard than others. And the challenge for health services is to try to hear and listen in an equitable way. Trisha, I know that this is something that you're passionate about. Could you respond to this question and perhaps refer to the broader community engagement that you've done, I'm guessing, as a response to this issue?
Sure, thanks. And that is a really good question, and certainly a really good suggestion. And I love that we're having a conversation partly around how do we do this better, but also partly around how do we label this, if you like, without actually labelling it. My background is actually in local government and community development. And so when I joined Queensland Health about 2 years ago, it's my very first time in health. And I guess I entered the organisation with a few assumptions. And one of the assumptions was that we work off a community-led development framework to empower and collaborate, genuinely collaborate and partner with our communities. My background is working in small rural communities where often their voices are not heard. And it's a real challenge because rural communities are different to city communities, to understand them. One size does not fit all. And while there is a lot of evidence in a lot of models that have been delivered across Queensland, I guess community-led development practice, one co-defines with the community what the issues really are. And so we're really quick, you know, as humans, as parents, as brothers and sisters, to try and jump to a solution, to try and fix something. But do we really understand what the problem is? And do we understand the problem from the eyes of the people that we're trying to provide a service for? So when I joined Queensland Health, I very naively thought that this type of methodology was already in place. And when I started talking to some clinicians around why don't we ask the community about the solutions, they started asking more questions around, you know, well, what does that look like? How do we do that? What does that mean? So I guess one example that I can give is a project that we're currently still undertaking and partnering with the community with in a community called Lowood, which is just sort of northwest of Ipswich. And we're focusing there on youth wellbeing. The first thing that we did was we went out and spoke to the darts club, we spoke to the Lions group, we spoke to the sporting groups, we went to the churches to see how they understood the problem. And then most importantly, we went out to the young people. We hung out in skate parks. We went to the schools. We went to, I think, about 12 feeder primary schools. We went to the youth service providers. We sent out surveys. So we had a range of different ways to be able to engage meaningfully with people. And every conversation we had, we said, even though we provide a service to the West Moreton region, we are not in your community as community members. So tell us what you see, how you feel. And then we started talking to the young people around what does this need to look like for you? Where does it need to happen? And we had some outcomes that, you know, were quite predictable, but more importantly, we had some solutions and outcomes that were co-designed that were just totally not on our radar. And doing really simple things like genuinely partnering with a club in that community has meant a really big difference to people's lives, young people's lives in the community. So I think it's around that change. It's around being genuine and listening. It's about being real and understanding it takes time because, like the panel members mentioned before, it's relationship building in a meaningful way. And it is very much around power balancing or trying to tip the scales back to place health back into the hands of the community. And we are here as support people to provide the support and some expertise to support communities through that journey.
Absolutely.
Yeah, so definitely passionate about making sure that we talk to the right people in the right place, in the right way, and whether that means we go to church services to connect with our Samoan communities or whether it means that we, you know, have a workshop with pizza, which is red food, to engage young people in a meaningful way, well, then so be it. I think we do what we need to. And I guess the only other tip is that we have incredible support from the top. So our board chair, our chief executive are just amazing and so genuine and saying, when I want you to go out and engage with consumers, they actually mean it. So, yeah.
Absolutely. That's definitely our experience of working with West Moreton's board chair, Mike Willis. He's a huge champion and so you're very fortunate to have his support.
Very lucky.
Janet, could I hand over and ask you, one question we heard several times during our online training of hundreds of Queensland Health staff last year was around cultural appropriateness, particularly when they would be engaging with Aboriginal and or Torres Strait Islander communities. Our team had the sense that health staff may have been holding back on attempting to reach out to First Nations consumers for fear of offending or for getting it wrong. What advice would you have for those staff?
I've worked for Queensland Health as a nurse and midwife for many years. My career ended a couple of years ago with Queensland Health. And so I've worked in rural, remote and urban settings. And as an Aboriginal person who has worked in communities overseas, and I was just sharing this morning with another group. When I went to work in Saudi Arabia back in the 90s, I had to do a full long year of orientation to that culture, that country, to understand the religion, to understand the cultural backgrounds of those communities I was going to be working in. And so I had to pass subjects that I really understood. So I did a whole year of that before going to this country to work for a couple of years. I worked in intensive care. As a young nurse, when I went to the Torres Straits to work, I just bought a plane ticket up there and I landed in community with no cultural training. But luckily I was astute and smart enough to understand to sit and watch and learn and not to put my values and beliefs on a community that I had just stepped foot in. And what I have found, because I have been across a lot of communities in Queensland, is there's now a high rate of agency nurses working for Queensland Health who have different cultural backgrounds, who have never worked in community before and have had little cultural awareness training. Cultural awareness is a box you can tick and flick. We understand now that it's cultural capabilities and being culturally safe when you're working in with our mob. So for health workers, it's all about them doing the work about learning about our communities. As an Aboriginal person, I'm not an expert in Aboriginal and Torres Strait Islander people all over this country. All I'm an expert in is my own Aboriginal journey and my family. And so I think health workers have to understand that there is a whole array of Aboriginal and Torres Strait Islander people, and what fits for one person, and this goes for all culturally and linguistically diverse communities and groups. What works for one people might not work in another rural setting versus another remote setting versus working in Brisbane, Townsville, Cairns or Sydney. So I think it's all about being honest and doing the work yourself, going beyond cultural awareness and really understanding. And as an Aboriginal person who never visited Mornington Island or Doomadgee or Normanton, I made sure before I went to that community that I understood the history of that community, that I understood the language groups, their totems, their customs, and that prepared me. But when I land there, and even though I might have learnt that, I know that I still have learning to do. I still have to take a seat back and I have to watch and learn. The other thing I would say to health workers is to be honest when you don't know something, okay? Be honest, go look. And don't assume that everyone wants to be called auntie or Mrs. or their first name. I've always asked people, how will I refer to you? And they will often tell me, oh, just call me auntie. Oh, just call me Ruby. And I worked in a very big regional hospital where there was a lot of Aboriginal women and their families. And a lot of those communities, I don't know those people, but I think it's about a human approach. It's about being dressing appropriately, because when I had to go to Saudi Arabia to work, I had to understand that how I dress back in Australia is not how you... And I think you have to understand that Queensland is made up of different countries. When I say countries, I mean, you're talking about, I'm a Butchulla woman, but I have connections to Mununjali country, I have connections to Wapabara country. And I have to understand that when I move in different countries, that things may change, nuances may change, something that worked for me really well here. I think I've never been afraid to make mistakes, but when I've made a mistake, I've learnt from it. And I think when you know, as I love quoting Maya Angelou, when you know better, you do better. And that's what I say to people, health workers. When you know better, you do better. And don't assume that when you come from Melbourne or Sydney and you come up to a rural and remote community and you've gone and done your cultural awareness training, that's where it ends and you tick a box. Cultural safety and cultural capability is an ongoing process. So I would say connect yourself in community, like any community you go to. Learn from the elders, connect with young people, go to nursing homes. Just like, I've forgotten your name in the middle up on the screen, like you said, go to places where people congregate, where they're real and that can show that you're trying to connect and learn about communities. I hope I've answered that question. I think because I have actually worked with a lot of practitioners who have come straight from university, I would say to them, take the time to listen to understand, not listen to respond. That's another. And remember that the people that you're taking care of, they're the experts in their own lives. They know the solutions. They just need you to be the facilitator of that pathway and to advocate for them. I had to learn on a very long journey of working nearly 30 years in health that I had to have the ability to question those in authority. And I think when I speak about authority, I mean the obstetricians, the registrars, the consultants, the ones that had more years of learning, but I had to come back to my gut instinct when I knew something was wrong. And I would rather speak up and advocate for someone and be wrong than not speak up and something happens. So I'd also say to them, challenge the status quo. You know, when you know better, you do better. Yeah.
Oh, that's wonderful. Thank you so much.
You're very welcome.
And I loved what you said about that it's everyone's responsibility to do the labour, to learn how to interact from a place of cultural safety. And we know that when people feel safe, then they are safe. It's about safety and quality of healthcare. And for us, it's also about the trust that consumers place in us when we listen to their voices. And Anne, I'd like to ask you, you've had many consumers at over 200 kitchen tables place that trust in you and in us. What impact, and I know that you do that beautiful job of going back and closing the feedback loop with them to share the impact that you have seen, but in general across all of those kitchen tables, what impact have you seen their voices have on the health system?
You know, I think it's the storytelling that comes from these sessions that's so incredible. And I've heard from Queensland Health staff and from other organisations that we work with, when they read the quotes and what people actually say, because what the host is doing is actually writing down the words that the person is saying, each person is saying individually. So it's not like a survey, or it's not just giving us dot points. They're actually telling a story. And when you share that back, they actually feel it. They actually get the emotion that's coming through, and it does have a very strong impact. And I think from hearing from health staff, that's the thing I'm hearing the most, is that incredible impact it's having on them emotionally, and how they want to improve the system for that very reason. I think for the people who are actually the participants in the kitchen tables and the hosts, the amount of feedback that we get that is so incredibly positive, and how important it was for them to be a part of something like this. As Janet said, you know, to have their voice heard is, you know, they may never have it heard otherwise. To tell a story that they may never have got to tell to someone else. It's such an opportunity for them, and they feel listened to. And I think that closing the feedback loop, which is where I hold a session with the hosts following, once I've got all the results and, you know, the report is written, we know the themes and the outcomes, is to say to them, you know, this is what came out of that. Can you please share this back with your participants? So, yeah, we don't just leave it, because one of the issues around people being hard to reach, I actually think, comes back to the fact that we consult and we consult and we consult, but often we never go back and actually say what happened out of that consultation, or whether that consultation even worked. And then 3 or 5 years later, we go back and we ask the same questions again. People become very hard to reach at that point.
I can see you nodding, Janet. Yeah. Christos, can I ask you a question from the audience? Why are we so afraid of getting it wrong?
From the department's point of view, and I have had worked in major campaigns with the departments and from the consumer. I think it is a matter of embarrassment, I mean by political embarrassment. It is a matter of costs. And also it is the problem is one of knowledge about how to go about dealing with something we don't know in terms of consumers. And also because minorities, and I talk about minorities because all these groups that we're addressing are little minorities within the bigger majority. Minorities are very critical of anything that comes in the media that is against them. So they're always on the watch out. So getting it wrong is very easy. The important thing, and I really want to throw the challenge here, both to Health Consumers Queensland and to Queensland Health. As a social marketer, I know that it is expensive to really reach consumers out there. It's time consuming, it is expensive, because you need to understand where they're coming from. You need to be able to understand well enough to build empathy in them for whatever it is you're putting across. And you need to have that communication with them. But when you have all these different groups, the first mistake we make is take a document a piece of paper that we're going to send out to the general community and then translate it. And this is probably the worst thing that we do most of the time. So my challenge is that we need to do, because we know, because we have all these groups that need that information, including health as well, who the groups cannot afford it. We need to have up-to-date research curated in a way that's accessible to all the groups, if we are going to ever get out there and actually reach those we kind of consider as not being able to reach right now. And the other thing that we need is we need to be innovative about reaching the consumer. Let's forget about what we knew before. And not make assumptions. I remember, my own assumptions. When I first came to Australia, and I started working in, I was going to work in Aboriginal community. My view of Aboriginal people was something like this mass of Aboriginal people. So I arrived in a community, and there are 57 language groups in one community. So let's not make assumptions. The next one is we need to build and to connect and build collaboration and trust for them to come to us. And empowerment is probably the most important. And that's something that we can do right now. We can run programs and services that actually empower the consumer, advertising, to tell them how easy it is for them to bring their voice to us. So there is a lot of work to be done. And look, I feel so good that in Queensland we've got health consumers. It's really very tight-knit, at least the services that we get out there in the organisation. But I think we need a lot more. We need to move to the next stage.
100%, and we're up for the challenge. So there's a few comments in here that I'd love to share from the chat online. One person said, I found that kitchen table discussions enable relaxed consultation with consumers who may be socially isolated, not able to use digital technology or not comfortable participating in formal meetings. Feedback from these consumers is valuable and may bring different perspectives to help improve health services. And I know we've certainly had a lot of gratitude from the health services who have engaged us to do that consultation work, and in fact even from the parliamentary committee in health who have inquiries on new pieces of draft legislation. They've been grateful not only for our organisational perspective on issues, but the fact that we're able to provide the consumer voice from so many different communities on sometimes really challenging topics. There's also another comment here from Maureen. Hi, Maureen. The use of Zoom has opened up my world in making better health information accessible. Living 1,000 kilometres from Brisbane means I still get informed without the travel. So we're so glad. It's been a tough 18 months, 12 to 18 months, but we're so glad that there has been benefits like that that have come out of this time. So just checking the time. Yep, we've got time for a few more questions. Let me just have a look. I guess now it might actually be nice to throw to a more general conversation. I wasn't sure that we would have the time for this, but I guess I'd love to just hear general tips and tricks from the whole panel, anything that maybe you haven't had the chance to share throughout this time. Maybe some examples of, say, the alternative to what Christos was talking about when an info sheet is translated and that's it. If there's been any really good examples of co-design with particular populations that you've been part of or you've facilitated, we'd love to hear them. Would anybody like to share?
It's Hamza here. For example, with in the early stages of the pandemic, and I suppose it's ongoing now as we start to think about things like vaccination rollout and some of the myths around the vaccination, I've seen attempts where information was essentially Google translated, and somehow people feeling very brilliant about the fact that we've got this information available in different languages. And I received this leaflet, and it was actually in the Urdu language. And I thought, let me just concept test this with somebody who's quite proficient with Urdu. And he says to me, this is the most offensive piece of information going. So, it just makes no sense. It's not in context. And so we were able to co-design that whole information with representation of that Pakistani community and get something out there that took away some of the fear and anxiety around, at that stage, about COVID testing and how that works. And if you're an international student or a temporary resident, whether you're able to access that. So I think sometimes what we have is an intent to want to do the right thing, but we don't necessarily put our thinking caps on and use a bit of emotional intelligence to think through, is what we're looking to achieve, which is a good outcome around making information accessible, actually accessible. So it might seem common sense and elementary on one level, but actually it surprises me even now how sometimes those basic steps don't happen and they should happen. And I think, as I sort of think through stuff and just synthesizing some of the conversation that's happened, I do think though that what we do have in Queensland is a continued investment and commitment by health and by HCQ and others around relationships, and we must guard and jealously guard those relationships. I think that's important because what that does is that becomes, to use a COVID type of analogy, I guess, an ability to inoculate against exclusion and being hard to reach. Because as I said, I personally think we will agree that hard to reach is really a bit of an excuse if you don't, it's a substitute that says we failed at relationships. So investing in relationships is really, really important. I do think though, I want to up the ante a bit, Melissa, because I think we've all been very polite to each other, and that's good, but being polite to each other and strong relationships means you could be robust and put the challenge out there, right? And so for me, the next thing is that whilst we still guard with the relationships, what I would like to see, and I hope John Wakefield and your mob are listening there, wherever you're listening from in this, or that you'll watch the recording later on, is that beyond the relationships, what we've now got to do in Queensland, and I think we're well placed to do it, which is why I'm putting the challenge out there, is we've really got to embed that lived experience, that consumer voice in the governance structures and do that much more than what we're doing. I think there are examples of that happening, but we have HHS boards and we have statutory regulation that says boards should be representative of the communities that they serve. Well, I'd like to see that being explicitly inclusive of people with extensive lived experience of the healthcare system. They've got to be having a seat around the table at the highest level of decision making if we're true about this. And I think there is a commitment there, but I think that should be an explicit thing. We know that health is complex, whether you're dealing with your GP, primary health, or whether you're dealing with a specialist tertiary facility for ED or as an outpatient. And we've got to make sure that if we're going to turn or to reverse this whole thing about hard to reach, not only do we invest in the relationships and the representation, but but we also invest in building capacity and supports for people to be able to make it to meetings, to get the training, to learn the language, because often, you might be talking two different languages and they're all brilliant languages in their own right, but if you've got no medium in which to sort of understand what the other is saying, you're at risk of going round and round in a circle. So I think we've got some really good runs on the board here in Queensland that we've demonstrated through COVID and in advance of that. But now it's about sort of taking it to the next level where we say, the next discussion that we have, it's not hard to reach. It's actually, what are we going to do to invest in putting the supports to place so that nobody is hard to reach?
Absolutely, and I keep thinking, what is the cost of not doing this?
Yes. Yeah.
And that not what it does cost, but what is the cost of
Yes.
not doing it? It also reminded me of a question I wanted to put to you, Janet. I think not only do we all need to make a commitment and put action into place to ensure that diverse range of voices at the board level, as consumer representatives, we need to ensure that they are diverse and representing their communities, but also workforce. And I've heard Haylene Grogan, who is Queensland's first Aboriginal and Torres Strait Islander Chief Health Officer and Deputy Director General of the new Aboriginal and Torres Strait Islander Health Division, talk about one of her key goals and passions is making sure that there is diverse representation and that Aboriginal and Torres Strait Islander consumers see Aboriginal and Torres Strait Islander people at all levels of the workforce, and that will actually improve that true cultural capability of the system. Would you respond to that and how you've seen that play out or not?
I've seen some amazing changes over the course of my life as a professional working in different communities. And when I first started back in 1984 at Rockhampton Base Hospital, I was the only Aboriginal person probably in the nursing workforce. I didn't see anyone that looked like me. People would often assume that I was the cleaner. People would often assume that I was visiting. Even when I graduated and became a registered nurse and worked in private hospitals, people thought that I was anything but a health professional. It was so strange. But I guess I came from a family that valued education and valued that I remain respectful at all times, even when I was being disrespected, because I guess that's been the underlying force for me, is that I'm in a position really where there is an imbalance of power. Even as an Aboriginal person, I've got power over another person, that's lying there sick in bed, and I don't think you realise the imbalance of power until you become a patient. And I've been a patient a few times in the last few years, and I tell you what, when that is a role reversal, you realise how much power is at the end of your bed standing there. I do agree with what Ms Grogan has said, and so there has been changes in terms of I now see more faces that look like me in the hospital and the health setting. I also understand, and I don't know if the panel understands, that Aboriginal people and Torres Strait Islander people come in all different shapes, sizes and colours, and to never assume and to ask the question if you're unsure, do you identify as Aboriginal and Torres Strait Islander? A lot of non-Indigenous people get really uncomfortable with that question. And I go, well, why should you be uncomfortable? What's making you? I'm curious. Why are you uncomfortable? And so I would say to that, we've been uncomfortable all our lives dealing with a health system and government policies that tried to assimilate us, tried to take away our belief system, our culture, our law, LAWLORE, our language. And so we've come from a place of, we are starting to have a voice that feels like it's being heard. There's still a lot of challenges in that process. And I think we have to realise reconciliation is about action, and I did a talk on action and what that actually means for people. We need allies, and we need to be allies for all people, because there is an imbalance of power in the hospital system. There's an imbalance of power in communities. We are not the experts. We are there to facilitate healing and people to be able to feel safe in accessing services. And yes, we definitely have come a long way, but we have still a long way to go. And what the table talks have done is about I'm not there to empower someone. I want the person to empower themselves. I'm there to provide the information, a conduit, if you like. And it's about I empower myself, and I empower myself by learning more, listening more, acknowledging, because until you come to the truth of what's happened in this country, because I'm a second-year university student, and young people who've left school still don't know the history of this country. I went and spoke to some social worker students who are finished out after 3 or 4 years, and I said to them, do you know where Cherbourg Aboriginal community is? And they never heard of it. I said to them, do you know where Arakoon is? No, never heard of it. Warrabinda, Hopevale. And I said, well, you're going to have patients coming to Brisbane, and you need to understand the history of this country. This history of where you're working, so that you can facilitate and understand why people don't speak up for themselves. So I'm one of these people that I have to go back. What was the question again? And just to reassure myself, because I get so passionate about it. And I think too with the younger generation coming through, I used to be a very angry young woman, like, why is this happening? But now I'm more curious, I'm more what's going on for you. And I tell you what, I have put out so many fires just by the simple words of, because I've worked in A&E and ICUs, and I've walked out and there's people angry and they've got mental health. And I go, I'm just here, I'm curious about you, what's going on for you. Can you share your story? And those words have got me out of so much trouble. Even the other night, can I just say this? I was at Royal Brisbane Hospital the other night. I damaged my arm. I had to go and get an X-ray. And an ED department is where you learn the truth about how people treat each other. Not just the health staff, but the people waiting in the room. There was a homeless man. There was someone who... And I can pick an ex-drug addict just like that, because I know, because I've been 30 years in the business. But when you sit and listen and talk and listen to their stories, this was a young Aboriginal man. I didn't know he was Aboriginal until he told me, because he didn't look, he was quite pale skin. But I listened to his story, and when they called me to have my X-ray, and I was gone for 40 minutes, and I came back and I realised I'd left my power charger there, that gentleman had put it up at the desk, and he goes, "Sister, auntie, your power, it's up there." And I thought, because I took the time to listen and talk to him, he became a human being to me, and people were avoiding him. I could see they were avoiding him. And this is what we've got to not be afraid of. When you said hard to reach people, they're not hard to reach. We're the ones that we're the hard to understand. It should be reversed. We need to understand. They're not hard to reach. They're actually easy to reach when you listen and you treat them as another human being. Yeah.
Here.
Beautiful. Thank you. Oh, well, look, that's a beautiful sentiment, I think, to finish on, and that reminder that this is really about sharing power with everyone in the system who deserves compassionate care that meets their needs and delivers on what matters to them. So thank you all so much. I wish we could keep talking all afternoon. We just might, those of us in the studio. Thank you all so much for coming in, and for those of you joining us online. This will be available to watch again tomorrow. And then we look forward to you joining us for our final session. Any broadcasters out there who'd like to offer us a broadcast deal, we are available for weekly shows. But our one episode that we have left is an evening event. So please dress up in your after 5 wear, or pull on your slippers and be ready with us to kick off at 6 p.m. on Thursday for a conversation about value-based healthcare, what it means for all of us. We'll have a fantastic panel of guests, and we look forward to you joining us for our final episode. So thank you all. Thanks, everyone.
Thank you.
Thank you.
Bye.
Thank you.
Bye.